So good evening, one and all. At the outset, I would like to thank the chairpersons as well as the trend organizing team for giving this opportunity. So this is more of practical point. I will be a little bit clinical applications and what are the pitfalls in laboratory testing in endocrinology, and my overview of when to do the sample and how to collect and what are the various assay methods and what are the interferences, because lot of interferences. Just now back you spoken about Dr. Krishnan Swaminathan spoken about the interference in the pesticides, and so drug interference is there when measuring the various hormonal tests, and a little bit about clinical implications that can be useful in day-to-day clinical practice. And before doing any lab test, and you should know about what are you going to measure and why you are going to do the test, and what are the advantages and what are the pitfalls of the particular assay or the test. So why lab diagnosis is required is one is we have to confirm. Many of the times the clinical diagnosis itself is enough over gross hypothyroidism. So no one may miss the gross hypothyroidisms or acromegaly in many of the situations. And to yearly diagnosis of the disease, again it is very essential. The more one is a subclinical hypothyroidism, the common one. And another extent is to assess the severity, so how much the test is, the clinical condition is severe, and to underlying the treatment response, whether whatever treatment we are giving, the patient is responded or not. And the last one is a legal aspect. So we have to document everything for a patient's benefit as well as from our own benefit. So these are the various indications to recommend the lab diagnosis. In endocrinology, the battery of tests is there. Starting from the pituitary to the gonads are all metabolic parameters. So the most common one from head to foot is the pituitary hormones, maybe a growth hormones or maybe a gonadotrophins, LH, FSH, or prolactin, or various hormones. And in thyroids there may be a T3, T4 or TSH, and pancreas may be a glucose or insulin or C-peptide, and adrenals. So there may be a renin, aldosterone, cortisol, and gonads, testosterone. So the lot of battery of tests are available, and so when to do and what to do, that is very essential, and because we have to minimize the errors. So this is the basic concept that it is very, very important to order only the test you really need. So don't order the unnecessary tests or unnecessary investigations, it will end up in a trouble. So most common in our day-to-day practice is a mastical checkup. So you may be come across a lot of labs, even they measure the serum levels of arsenic or lead or mercury. I don't know how much it's reliable. Some of the times patients also may be very panic whether it is how much reliability is there. So you order whatever test you need, because the extra test means it means a false positive many of the times. So the clinical diagnosis is very essential, and so you according to the clinical diagnosis you go by the investigations. So before any pitfalls, it can be broadly classified into three categories: pre-analytical, analytical, that is whatever happened in the equipments, and post-analytical, once the report is ready. So the most common errors or pitfalls as a pre-analytical level. So this is from the multiple study, and it's around 70% of the errors or the lab pitfalls are because of the pre-analytical. So pre-analytical may be a sample collections error, a transport technique inadequate, or inadequate sample and container of the samples, so on and so forth. And regarding the analytical is equipment malfunctions are depend upon the assays. Post-analytical is quite rare, and it is basically a typographical errors many of the times. And in endocrinology, basically the types of sample we can divide it is either whole blood or serum or plasma. And urine, some of the tests we requiring urinary sample, and another one is the latest is saliva, particularly whenever you are doing a cortisol estimations. And similarly the container and transport. So the container may be a plain vial, or it can be a EDTA vial, or it can be a fluoride. So fluoride is very essential whenever you are doing the glucose estimations, because it inhibits the glycolysis. So spontaneously, otherwise glucose level will come down whenever you are doing a glucose sample in a plain vial. And similarly the transport. So the transport is in endocrinology very important. Is a two essential hormones, ACTH and PTH. That is a adrenocorticotrophic hormone and parathyroid hormone. So basically it is a fragile peptides, and it has to be collected in the pre-filled syringe and it to be separated immediately and it to be transported, it should be maintained in a cold chain because it is a very fragile peptide, so we may get falsely low. So we may miss the diagnosis of some of the Cushing syndromes whenever we are falsely doing the preparations for ACTH and PTH. So one should keep it in mind, these important two areas. And coming to the most common one of glucose estimations, so the plasma glucose is about 12% greater than the whole blood. And there is a fasting state, there is not much difference between arterial, capillary and venous. And following the food intake, there is an increase in the capillary samples. So the glucometer glucose may exceed the venous sample by as much of around 30 to 40 milligram per deciliter. So coming to the timing of sample, and in endocrinology is a very easy to do sample in a fasting because it is a basal state and lot of the hormones in a circadian rhythm, lot of the hormone is in a diurnal rhythm, particularly the sex hormones like testosterone and circadian hormones like cortisol. So if you are doing any lab test, particularly in the early morning around 7 o'clock or 8 o'clock, it is a basal state and we may minimize the mistakes. So it is very easy and very essential to counsel the patients. Many of the times we have to call back the patients on say next day, and in a private practice maybe we may chance of missing the patients, so one may do at any point of time. So it should be avoided and we should do it as a fasting level and basal level. And in a female patients and regularly menstruating, we should do at a follicular phase because the luteal phase lot of interference with the progesterone. And similarly, the random sample may not be useful, particularly the single most example is a growth hormone. So either deficient state, you have to do the stimulation test like clonidine or insulin tolerance test. And similarly, in acromegaly, you have to do the suppressant test. So the random growth hormone assays is not going to be useful. And in my DM state, there was a pooling of samples. So it's a pulsatile release. So you may miss the single point of time. If you are taking the sample, you may miss the value. So you do the sample at a 20 minutes interval and you collect the sample in EDTA. So you may pick up some more number of cases. These are the various methods. And coming to the food interferences, so one of the important thing is a triglycerides. So the post meal, if you are doing the triglycerides, it will be always high. And similarly, some prolactin, glucose, IGF-1, sex steroids, they have some interferences with the food. And thyroid profile, better if you are doing in the morning hours, it will be more useful rather than to pick up the early cases. And collection sites, so if you are tourniquet is during phlebotomy is very tight, so there will be falsely elevated calcium, phosphate, and as well as the potassium level. And similarly, if you are doing the sample at the same IV fluids is going, if you are taking the same samples, there may be a chance of dilutions, and already highlighted about the venous and capillary glucose. In endocrinology, these are the urinary tests. It's urinary metanephrines, 24 hours urinary metanephrines, and metabolites are always most sensitive rather than the precursors. So that is one of the gold standard tests for the most sensitivity is a 24-hour sample. Either again it is a collection problem is there, but we have to instruct. And similarly, the 24-hour urinary free cortisol and 24 hours urinary calcium, phosphorus and creatinine and urinary iodine, even though it is commonly not available, and similarly 5-hydroxyindole acetic acids. And the spot test can be in a urinary albumin. It also can be falsely positive whenever there is a severe glucotoxicity is there. And this is the particular to the pheochromocytoma. So in olden days, the VMA was more commonly used, but it is sensitivity is very less. So any test you want to have, it should be a good sensitivity. Similarly, it should be a good specificity. So VMA sensitivity is around 60%, and the free hormones like metanephrines and total metanephrines in a urinary metabolite, it has very high sensitivity and specificity. Similarly, the plasma free metanephrines, they have very sensitivity and specificity. So we have to individualize what to order and when to order and what are the interferences. So the pre-analytical, collecting the thing, it is a sampling mistakes, venipuncture site mistakes, specimen the tube and handling errors, and at last the lab technicians mismatching the sample. These are the pre-analytical point of view. What are the pitfalls you may expect or you may anticipate? And coming to the analytical pitfalls. So the assay methods we can broadly classify into immunoassay as well as the mass spectrometry or liquid chromatography mass spectrometry assay. So the immunoassay is currently what we are using. So the first and foremost is the radioimmunoassay. It is a 1960 or 1950 it was evolved, and we need radioiodine ligand and 125, and we have need permissions from the Atomic Research Institute. In those days, many of the hormones was done in radioimmunoassay, like growth hormones and a lot of testosterone, and still many of the labs, some of the labs, they are doing 17-hydroxyprogesterone by radioimmunoassay. Similarly, the TSH receptor antibody has been done in radioimmunoassay. Only disadvantage is technically challenging, and the need trained persons, whereas the CLIA, the commonly what we are using, the third one, chemiluminescence or immunochemiluminescence assay, it is a very equipment friendly. We don't need human intelligence, not much requiring. Just you load the samples, the report is automatically will come within an hour. And in between was ELISA. So ELISA is now outdated almost, and very few tests or very rare tests we are using this ELISA. So the gold standard one is what we want is a mass spectrometry, liquid chromatography or mass spectrometry. So advantage and disadvantage I will be discussing. So in those days it was a first generation, so pickup rate was very minimal. Now we have 4th generation, so we can able to pick up less than 0.005. So this is the thing, and the equipment also has a lot of interferences. You can see that the TSH is a very good assay. Almost all of the equipment, Abbott, Beckman Coulter, Roche, almost the TSH is correlating very good. Whereas the free T4, you can see that there is a large of variations is there. Even though free T4 is a biologically active hormone, the assay wise TSH assays are well validated when well standardized comparing with the free T4 assay. And similarly the free T3 assays also, many of the labs they are not well standardized. So we need free hormones. So for the free hormones we need better equipments like equilibrium dialysis method. So we can do by liquid chromatography only, not by the immunoassay method, because it is not much validator comparing with the bound assays, and it is expensive and availability also is less. So these are the what we want in future, the chromatography methods. Only thing it is a crores the equipment is, and because we need a large volume of sample, otherwise it is the parameters is going to be wasted. And the steroid hormones, this is the gold standard one, that is a liquid chromatography and mass spectrometry, because each according to the each molecular specific we can able to diagnose the steroid molecule like DHEAS, cortisol, 17-hydroxyprogesterone, testosterone, DHEAS. So all of these hormones, this is the gold standard. Hope we may expect this thing will be available in near futures, and this is the modern era to minimize the lab errors. And so the referral range was detected from the normal populations. This is, for example, I have put it for the thyroid. So thyroid is a quite common disease. So it has taken as a 2 standard deviations, 0.5 to 3. So less than 0.5, below 2 standard deviations, more than 3, that is a 95th percentile, that is above 2 standard deviations. So the in between was taken as a referral range. So this was a larger populations, whereas in small volume of diseases, 1 standard deviation was taken. And so the special populations, there is a special referral range. None of the laboratory will mention about these referral range. So we have to keep it in mind. Newborn, term and preterm infants, pregnant individuals, obese individuals, now we are high BMI, they have high TSH value, elderly and critical illness. So these are the various pitfalls you have to keep it in mind whenever you are interpreting the laboratory diagnosis. And some of the examples are discrepancy between the T4 and TSH. So T4 also high, TSH also high. So because of this binding protein interactions or interferences, it can happen in pregnancy, in newborn patients, those are on OCPLs. So this is a thing we have to keep it in mind. And similarly, one of the things is common mistakes is sick euthyroid or low T3 syndrome. In critical illnesses, there is a lot of interferences, cytokine mediator interferences, as well as the agents what we are going to using, steroids, inotropics, dopamines, everything has interferences with these various assay. So we have to keep it in mind and interpret. Unless very strong suspicion is there, don't investigate many of the patients in critical care setups, because entire things has been shifted. Circadian rhythms also shifted, diurnal rhythm also shifted, and cytokine mediated. So it will be very, very difficult to interpret whenever you are doing any hormonal test in a critical care setup. Even Cushing syndrome is also very, very difficult to diagnose in critical care setups. And so the lot of interferences with proteinemic conditions, burns, age, so we have to keep it in mind. Coming to the analytical validations, this is a gold standard, how to we have keep it in the lab or how to keep it in maintaining. So the term is a precision, so that is a, already you heard precision medicine. Similarly, it is a replication of repeated measurement of the same specimen. It can be a internal quality control, or it can be a external quality control or external quality assessment. So we have to send the samples to the different laboratory, but method should be a same one, and we have to compare how much variations. So in a statistical point of view, we used to tell as a CV, coefficient of variations. So various hormonal, there is a various CV has been documented in the literatures, and we have to be take it in this account. Some of the hormones are very good CV, some of the hormones are less coefficient variations. So the precisions also is very essential. All the things we have to keep it in mind. And drug interferences with the assay. And this is all very rare, but this is one of the papers, the endocrine review. They have thyroid interference assay, but it is quite uncommon, but we have to keep it in mind. Patients is clinically euthyroidal, but TSH is persistently high. So what are the possibility? So one of the possibilities is macro TSH, and another possibility is this anti-mouse antibody or anti-heterophil antibody. These are the immunological interferences with the TSH assay with particular the patient's antibody. So we have to either we have to repeat the test in the different laboratory or different methods or different assay. We have to use it to define. So this is quite rare, but still we have to keep it in mind whenever there is no correlations or predictions about clinical correlations are there. And one of the things are hook effect. It is particularly more common in prolactin assay. So whenever there is a very high prolactin level, it is also has interference with the immunology, and it is coming as a falsely low. And any patients with the high prolactin with the regular cycle, always you suspect macroprolactin, and there is a PEG methods also available, and drugs also we have to keep it in mind. Many of the drug-induced hyperprolactinemia, there will be a high prolactin, but patients will be regular cycle. So many of the times prolactinoma is ruled out. And cross-reactivity also we have to keep it in mind. That is a HCG assay. They are glycoprotein hormones. So they have LH, FSH and TSH interference. And similarly the cortisol assay. So the best one is the steroid-specific hormones. And drug interference, a lot of people now using alternative medicines. So always the cortisol assay has interference with alternative medicine use. So our history taking should be, again, it should be very standard. And similarly the liquorize use. They have hypokalemia and hypertension, and whenever you are doing renin aldosterone level, lot of anti-hypertension has interactions like beta blockers, clonidine, ACE-ARB. So everything we have to keep it in mind whenever you are ordering some investigations and interpretations of the value. And this is the reason one that biotin interference. So biotin is one of the micronutrient and microvitamins commonly used. It also has interferences with the thyroid profile report. Again, history taking will give more clues and more ideas. So the thyroid commonly age also affect iodine status, smoking, timing, and assay interference. This is as a summarizing the overall. This is the some last couple of slides. So in diabetes mellitus, again timing of sample, container, sodium fluoride I have told, and HbA1c method. Among the HbA1c methods, the anemia interferences. So you can see that any patients of severe anemia don't do HbA1c. It will be falsely misleading you. In case of iron deficiency or B12 deficiency, HbA1c is going to be falsely elevated. Similarly in renal failure also. So these are the interference that can be minimized in practical approach. Similarly in hemolytic anemias, you may expect low HbA1c, and so you want to minimize the mistake, always you have some counter check. So you can do counterbalancing, like if you are ordering TSH, you do either T4 or free T4. Similarly LH or FSH, cortisol and ACTH, GH and IGF-1, HbA1c with the sugar. Calcium should be along with the phosphorus and PTH. So you can minimize it doesn't correlate each other. You repeat the test or you repeat the lab or different lab. Similarly, whenever you are wanting glucose and insulin or C-peptide, you do the corresponding or simultaneous glucose. That will give you a more, at the point of time, how much is the thing. So coming to the summary and conclusions. So the most common source of error in lab diagnosis is a pre-analytical errors, and it need to be identified and easily modifiable. And clear understanding of the choice of the test and order of priority is very important to minimize the mistakes. And be familiar with the methods used and the age-specific cutoff like newborn, pregnancy, and that time was discussed regarding the elderly TSH and various interferences. And immunoassays will remain in the clinical diagnostics because it is a cost-effective, and mass spectrometry will be the future winner in the current steroid analysis race. However, a good and well-validated immunoassay is not inferior to the mass spectrometry, and single test is rarely sufficient to identify the interference. And communications, this is the most important. So always you have to communicate with the lab technicians and the quality control. So the lab technicians, clinicians and manufacturers, it is of paramount importance to limit the harmful consequences of laboratory pitfalls. So with that I am concluding, and clinical judgment should not be replaced by indiscriminate lab testing. So this is the one area we have to keep it in mind. So with that I am concluding. Thank you for your kind attention.
Thank you.
Thank you very much, sir. Thank you very much.
Dr. and Dr. Sahu to give the memento to Dr. Swaminathan as well. Thank you.